So thank you everybody for joining us. I'm pretty excited about today. I was just telling Z before we hopped on that the days that I don't present, we tend to get a really good turnout. And today is certainly not an exception to that rule. And so I'm pretty excited that you guys are here. And I'm also pretty excited to have Z presenting to us today. He is going to be talking about the use of point-of-care ultrasound for pulmonary hypertension. Certainly something that we don't routinely do down in the ED, but I imagine is going to be a staple of your practice upstairs in the MICU. And so without cutting into his time, I'm going to turn over to Z and look forward to hearing what you have to present to us today. So go ahead and take it away.
Thank you, Matt. So I'll try to make it as useful to the emergency doc as much as it is to the critical care doc. So I don't have any conflicts of interest, and I'll share that slide. But I just want to say that the goal of the lecture, of course, is to talk about the usefulness and limitation of ultrasound measuring pulmonary artery pressure, to follow an algorithmic approach to assessing pulmonary hypertension, stratification of the pulmonary hypertension, and to understand the role of other imaging modalities in diagnosing pulmonary hypertension. So let's go on here. So again, I have no conflicts of interest, no financial conflicts of interest, but I do have two equations. And the reason I say this in the disclosure, because I read a book a while ago that said if with every equation you lose half of your audience. So I hope I haven't lost 3/4 of my audience already with two equations. And I'll go over those in detail. This is the systolic pulmonary artery pressure equation using the tricuspid valve regurgitant jet speed squared times 4 plus the right atrial pressure. And this is the usual equation of cardiac output and pressure variable, pressure drop across the circuit divided by resistance, or cardiac output times resistance equals the pressure drop, something that is going to become familiar. I'm also going to use poll everywhere. So if you do want, you can go on pollev.com/ZSS if you haven't downloaded the app. If you have the app, then you can use it, and you choose again ZSS as the handle. The app might ask you, or the website might ask you to register. This is not me. This is Case Medical School. They won't let you vote unless you have registered. So do take a minute to do this. It will make it a little more fun. And at the end, we'll have a competition also on the same app. So the handle is ZSS. And here I start with a case, of course. Acute dyspnea 2 hours after COVID vaccine injection. So this is a lady who uses oral contraceptive pills and has history of smoking. She is on the heavy side. She did come in with progressive shortness of breath. It worsened after the COVID vaccine, but she says that it's been going on for about 6 months. She can't get around the house at all now. So it's been progressively getting worse. She does have lower extremity edema with tenderness. Their CBC chemistry are normal. BNP is high at 1500, and the troponin is pending. You do look at the EKG and you see troponin, because you're waiting for the troponin, you see non-specific T-wave inversions. You do a lower extremity ultrasound. Because of her body habitus, it is limited, but there is no DVT in the area that you can see in the area of maximum confluence and in the inguinal area. You do a cardiac ultrasound and you see a McConnell sign where the apex is hyperdynamic and the base is not moving much, so TAPC is low. You think, am I going to do a CT scan? Should I do a chest X-ray first? I'm thinking of a PE, but I'm worried about an RV infarct. You do go for the chest X-ray. And the reason you do this is because it's a good starting point, and because you remember that the right descending pulmonary artery can actually tell you if somebody has pulmonary hypertension. This is it. Although there's a limitation, because sometimes with pulmonary hypertension or with the artery being closer to the right atrium is going to silhouette the margin of the pulmonary artery, and you're not going to be able to measure it. But this is where you would measure it. The left pulmonary artery happens to be behind the structures here, the aorta, so it's difficult to see. The rule is that in females, the diameter of the pulmonary artery, the descending branch of the pulmonary artery, if it's more than 15 millimeters, that's abnormal. And in men, if it's more than 17, that's abnormal. My general rule, which I learned as a resident and I still use it, is 2 centimeters is too big. And then I go from there. And then you do get your CAT scan. The CAT scan, of course, is limited. It says there is no filling defect in the PA trunk, the right or left main arteries. But it also says that the PA is large and suggestive of pulmonary hypertension. The images, of course, said limited by poor contrast, opacification of the arteries, motion artifact, body habitus, clinical correlation, the usual. And then you have these questions. Can I use the pulmonary artery size on CAT scan to decide if there is pulmonary hypertension? And can I use it to decide on the degree of pulmonary hypertension, mainly the pulmonary artery pressure? There is an article actually that looked at this, and it was from 19 something, 80 something. And it looked at the main PA and branches of patients and controls, patients who underwent right heart cath, and controls who didn't go through right heart cath, but they were deemed normal without pulmonary symptoms. There were 32 of those who ended up with a pulmonary right heart cath, and 26 age-controlled, age and sex matched subjects. And in this group, using a cutoff of pulmonary artery diameter of 28.6 millimeters, so 2.86 or 2.9 centimeters, was actually predictive of pulmonary artery with a good sensitivity, good specificity. Good specificity. So they did have some false negatives. So these are 16 patients who were diagnosed with pulmonary hypertension eventually on the right heart cath, and there were 11 who didn't get diagnosis of pulmonary hypertension with a right heart cath. There were true positives of 11 and true negatives of 11 and false negatives of 5, which gives it a good sensitivity, about 70%, with a great specificity, 100% in this case, and an accuracy of 82, comparing the diameter of the pulmonary artery to right heart cath pressure of more than 18 millimeters of mercury. Also, you can use, if you have the right software, so this was a contrasted CT at end inspiration with a special software. If you have the software, and you can measure the pulmonary artery area, then you can use this equation, which I simplified from the original equation, which is here in faint because it's got way too many digits, to predict the pulmonary artery pressure in such a patient with a really good R value. This was the correlation coefficient between the observed mean pulmonary artery pressure and the predicted by CAT scan. The observed, that is measured by right heart cath, and this is the mean PA pressure predicted by the CAT scan. The equation is actually not too complicated. The mean pulmonary artery pressure equals 0.08 times main and right. The best arteries to use are the main pulmonary artery trunk and the right pulmonary artery areas, divided by body surface area. You add the 2, you divide by body surface area, and subtract 11 from this product. So, for example, if you have a pulmonary artery pressure, main pulmonary artery of 30 millimeters, so 3 centimeter diameter, and you have a right PA of 2 with a body surface area of 2, then you end up with a 30 millimeters mercury of mean pulmonary artery pressure predicted by the equation. And because this is non-invasive relative to a right heart cath, why not use it? I haven't seen a lot of people use it. Okay, so to set the standards here, pulmonary hypertension definition is a PA pressure of more than 25 or more millimeters mercury at rest. And I underlined at rest because with exercise, you do increase your pulmonary artery pressure because you increase your cardiac output. It's best, or the gold standard of measurement is the right heart cath. Normal is less than 20 or less. There is this gray zone of 21 to 24 where nobody really knows what to do with this range if you actually find a patient with such a PA pressure. Of course, there are many diseases that can cause this, including heart disease and lung diseases. And untreated pulmonary artery hypertension does result in high morbidity and mortality. And cardiac ultrasound is key in getting the diagnosis or getting a suggestion of the diagnosis. The first equation we're going to talk about here is what I said. If a person exercises, then they're going to increase their pulmonary artery pressure, and they do this because of this equation. So V equals IR is what you learned about voltage, current, and resistance in electricity circuits. If you change this to fluid dynamics, you have delta P, which is the voltage here. The current is the cardiac output, and resistance is the pulmonary vascular resistance. The delta P is the drop in pressure between the mean pulmonary artery pressure to the capillary wedge pressure, which is a surrogate of the LVEDP, left ventricular and diastolic pressure. And this equals cardiac output times pulmonary vascular resistance. If you exercise, you will actually reduce your pulmonary vascular resistance a good amount because you do have areas of pulmonary vasoconstriction because you don't use all of your pulmonary circulation all the time. And when you exercise, you open up these areas and you recruit these vessels to participate in the blood flow. So you have a good capacity so that your pressure doesn't go up and you can actually pump fluid through the circuit, but you're not going to be able to do as much as increasing cardiac output. So this is what happens in somebody who is normal, who goes exercising. Let's say if you start with a cardiac output of 5 at rest, and you have a mean pulmonary artery pressure with millimeters of mercury of 10, and you double your cardiac output by going up on a flight of stairs, then you will increase your pulmonary artery pressure, but not at the, so this would be the straight line increase, and the gray area is what really happens, what has really been measured in healthy volunteers who are exercised while they have a pulmonary artery catheter in place. So if you start here, you're probably going to follow a curve that's within the gray zone. And if you start up here at about 20, you're going to follow a curve in this gray zone. But you're not going to go up straight. So the dots I put just to show you where the line of identity is, what is the expected increase in pressure. So you don't increase your pressure as much as you think you should just by increasing your cardiac output, because you do use your vascular reserve to increase your capacity for the circulation. Okay, so there are, I said that pulmonary hypertension is actually dangerous, and it does carry high morbidity and mortality. The predictors of morbidity and mortality are not the pulmonary artery pressure, surprisingly. It is the WHO functional capacity, 1 to 2, 3, or 4, 4 being high risk, 6-minute walk distance in meters. If it's more than 440, if you can walk this much, or if it's less than 165, then you're considered in the high risk. And the BNP, or the NT-proBNP, they both had similar utility in predicting outcomes. So if the BNP is more than 300, or the NT-pro-BNP is more than 1400, then this is a predictor of poor outcome. These are also predictors: the right atrial pressure, the cardiac index, and the SVO2, but they weren't as strong predictors as those three other items. So for our patient who has functional capacity of 4, she's dyspneic at rest, who can't go around the house, so she has a limited 6-minute walk distance, and also has a BNP of 1500, she is in group 4. And what does that mean, high risk? That means she has a risk of mortality of about 50% in 2 years, or 2 and a little bit. So she doesn't have a really great survival, which is kind of scary. People worry about lethal diagnoses in general, cancer and heart failure, but nobody really talks about pulmonary hypertension as a lethal diagnosis. And in 5 years, she has a survival chance of about only a third. So that's why I said it is important to diagnose it right on the spot and not push it off to later. So if we start with the poll everywhere, this became max. Let me drag this. I wanted to see if you can answer this question here. Let's see, question 11. So pulmonary hypertension and enlarged pulmonary artery can cause. So go ahead. Which of these things you think an enlarged pulmonary artery and pulmonary hypertension can do? Anybody can vote, or let me check. I'll put him on this and see what happens. Yeah, okay. Okay, that's nice. 75% going all. I thought it was a tricky question. You have 13% saying hemoptysis by rupture of hypertrophied bronchial artery. Yes, this actually happens, and hoarseness by compression of the left recurrent laryngeal nerve, but also you can actually have coronary ischemia. Yeah. And there has been reports of dissection of the pulmonary trunk because the pressure was so high, resulting in tamponade. So that's great. Okay, let me see. I can move on. Okay, all of the above, you got it. Okay. So the WHO divides pulmonary hypertension into 5 groups. You might have seen these already. The pulmonary arterial hypertension, idiopathic, hereditary, drug toxins, shunts, connective tissue disease, portal hypertension, and hemolytic anemia. I put a star because it's bounced between group 1 and 5 a couple of times. Group 2, of course, this is not incremental by severity or frequency or anything. Actually, group 2 is the most frequent, which happens secondary to left heart disease. So valvular disease or ischemia. 3 is secondary to lung disease, including interstitial lung disease, OSA, asthma, COPD. And long-term exposure to high altitude is probably one of the main things that happen in certain countries. And CTEPH or pulmonary embolism related pulmonary hypertension and other PA obstruction are in group 4. And group 5 is unclear or multifocal causes, such as systemic diseases, sarcoidosis, vasculitis, and renal diseases related to group 5. Just so that you know, if somebody says group 2, they're talking about heart disease. Group 3, they're talking about pulmonary disease. Group 4 is CTEPH, and 1 is the primary pulmonary hypertension related to pulmonary artery disease itself. and 5 is the basket where you throw everything else. Using ultrasound to measure pulmonary artery pressure seems simple. The idea is if you change, if there is conservation of energy in fluid dynamics, if the pressure, if you have an area of high flow, you're going to have a drop in pressure, and if you have an area of high pressure, you'll have low flow. So this is called Bernoulli's equation or principle. So flow speed estimates pressure difference. That's how ultrasound is used to measure pressure. Ultrasound can only measure pressure. It can't measure, sorry, it can only measure flow speed. It can't measure pressure per se. So using Bernoulli's equation, where delta pressure is 4 times the flow squared, is the simplified version, which works very well for measuring the pulmonary artery pressure. If you're looking at this area right here, between the right ventricle and the right atrium, regurgitant flow between the right ventricle into the right atrium is going to happen when this pressure changes into flow, where the flow will have very low pressure but higher speed, which can be detected by traditional echocardiographic approach to the measurement. You add to this pressure difference by measuring flow. You add to this your pressure estimate from the inferior vena cava to give you an estimate of what is the pressure that already existed in the right atrium. You add this to the difference in pressure between the right ventricle and the right atrium, and you get the systolic pulmonary artery pressure. So we're not talking about the mean, we're talking about the systolic, and this is what it looks like. You use Doppler. You can use color Doppler to see the area of maximum turbulence, and then you put your continuous wave Doppler, not the pulse wave Doppler, but continuous wave Doppler, to find the area of the highest speed. You don't care about where it is, you care about what it is, how fast it is. And then the speed is going to be depicted as a signal that's going away from you. In this case, for example, the speed is 3 meters per second, and that predicts a pressure of 34.5. Now, this is not the pulmonary artery pressure. This is the pressure difference between the right ventricle and the right atrium. You add to this what you expect the pressure in the right atrium to be from the IVC. So you look at the inferior vena cava, you measure the diameter of the inferior vena cava and the variability during respiration, and we'll go over this in detail. And then you decide on what is the pressure in this area, and you add it to the transvalvular gradient. Okay, so it's going to look like this. This is the apical 4 view, and this is the tricuspid valve. You're going to put color in the tricuspid valve and continuous wave Doppler to see what the regurgitant jet is going to look like. The second view where you can get this, other than the apical 4, which you saw right here, is to get the RV outflow inflow tract, which is you take the parasternal long axis view the way you usually do it, and then you angle you tilt the probe. You don't rock the probe. You tilt the probe going towards the left, the right hip, and this brings you closer to the sternum. And then you don't see the the aorta anymore, and the mitral valve and the left atrium, but you see the junction between the right ventricle and the right atrium and the mitral valve and the tricuspid valve in between. So you can also do the measurement this way. That's another view you can get. And once you're in this area, so apical 4 and parasternal view, RV inflow, either apical 4 or RV inflow view, and then you put color Doppler on the tricuspid valve. You locate the jet away from the transducer right here, and you put continuous wave Doppler through the area of the highest speed, and then you you measure maximum velocity. That's maximum velocity, and that's going to be in meters per second. And then you go through the equation to calculate the number. In patients with trivial TR, jet, or suboptimal images, you can actually you can inject bubbles, agitated saline bubbles that will fill in the right atrium and the right ventricle, and will make the jet look much brighter on the continuous wave Doppler. So for example, here you have someone who's got a very poor image and an estimate of that you can't really tell how far this goes, the jet, and then you inject bubbles, you see the jet light up, and it becomes much easier to measure. Okay, and as far as the inferior vena cava, you're very familiar to this. You're going to take your marker. You can either freeze the image or you can use M mode on the image. If you can get the IVC in a horizontal view, you can use M mode. If you can't get it in a horizontal view, I suggest you freeze the image and then you measure the diameter about 2 centimeters from the atriocaval junction. This is probably the point below where the hepatic vein opens into the inferior vena cava. And from this, you're going to measure the size of the inferior vena cava, and the diameter of the inferior vena cava, and also the variability with inspiration. And the variability with inspiration is a little bit tough, because you can have a patient who you say taking a big breath or sniff, and they generate a -100 intrathoracic pressure, and someone who would generate only -10. So there are two ways to do this, either with tidal breathing or with a sniff, which I will come to when we talk about the algorithm. But this is what the ASE, the American Society of Echocardiography, use as a predictor of pressure based on variability with sniff and the absolute diameter of the inferior vena cava. So if you have a diameter of less than 2.1 and you have high collapsibility, then you consider the pressure to be 3 millimeters of mercury. The range is 0 to 5. And if you have a small IVC without much collapsibility, then you call it an 8. And if you have a large IVC and you have not much collapsibility, you call it 15. This number, for an odd reason, is not defined by the ASE. They don't call it 12, they don't call it 10, they don't call it anything. But the range estimate is 10 to 15 if you have a large IVC, but you do have collapsibility with inspiration, with a sniff. Now, another question. So I'm going to ask, the systolic pulmonary artery pressure at rest is an important predictor. So we're doing all of this to measure the systolic pulmonary artery pressure at rest. But what are we going to use it for? Is it important in long-term prognosis of pulmonary hypertension patients, therapeutic decision-making, who are you going to start on treatment, and what are you going to do with the treatment, assessment of worsening clinical status, or in predicting people with RV failure? So it's updated now, or none of the above, of course. So. You can change your answers, yes. That's interesting. So we have a good amount of folks saying it could help in therapeutic decision-making, and trumping the correct answer, which is none of the above. So let's go over these. Let's go over these one by one. Thank you. So the systolic pulmonary artery pressure is not a prognostic value. We know this because we looked at the WHO guidelines and predicting mortality for pulmonary hypertension. So, and it's not really, it shouldn't be really used for predicting therapeutic initiation of therapy. That's why when a person with pulmonary hypertension, we want to start them on therapy, we actually do a right heart cath, and we don't care as much about the absolute number. We care about variability or the change in pulmonary artery pressure, either with exercise or with therapeutic intervention. So we put them either on nitric oxide inhaled or on an IV treatment during the test to see what happens to their pulmonary artery pressure. Worsening clinical status can absolutely be because of increase in pulmonary artery pressure, but there are so many other variables, such as increasing worsening cardiac output or cardiac index, and a whole lot of pulmonary and cardiac syndromes that can result in worsening clinical status. We don't depend on the pulmonary artery pressure to decide if the person's clinical status is improving or not. We actually depend on one item, which is the 6-minute walk distance, which is very sensitive and very specific in deciding if somebody is doing worse or better. And the heart failure folks actually do this pretty much routinely. And in predicting RV failure, as you increase the pulmonary artery pressure, you're going to thicken the RV, so it's not going to really work for predicting RV failure. So I'm sorry, it was a very tricky question, but this is part of the guidelines, is not to depend on the pulmonary artery pressure for any of these things. Okay, but after you've measured the pulmonary artery pressure, and I'm sure you're going to go out and do it today, you want to realize that there are a few limitations to your measurement. One, the peak tricuspid velocity jet signal measurement. There is an error. If there is an error in it because you're not exactly in line with the jet, then you're going to square that error and then you're going to multiply it by 4. What does that mean practically? It means if you have someone with a jet velocity, say of 4 meters per second, in this case, 4 meters per second, and you square that and then you multiply it by 4, you're going to end up with a 64 PA pressure, millimeters of mercury PA pressure, if you're exactly in line with that jet. But if you're at, let's say, such as in this case, at 20 degrees off, then this reduction in the measurement from 4 to 3 is going to push you down to 56. So about 10 points difference in the pulmonary artery pressure. This is still this is a 40 degree, there's a 40 degree deviation, but a 20 degree, which is considered acceptable measurements, a variability of 20 degrees, which is considered acceptable measurement error, still gives you 10 points difference or 8 points difference in someone who has a little bit of a good amount of hypertension. So when you read on the echo reports ±5, actually they are serious about the ±5. So a little bit of deviation from parallel will give you this kind of drop, and the farther you go from parallel, the worse the drop becomes. And this, if you remember this is the plot of cosine theta, and the signal doesn't change in the first 10%, but then after that it starts coming down pretty significantly. Okay, the second problem that you might find yourself faced with is the right atrial pressure estimate error. It seems that on literature search, the right atrial pressure estimate from looking at the IVC relative to measuring it invasively is pretty big. And the measurement is only accurate about 34% of the time. There are multiple schema for measuring predicting the right atrial pressure from looking at the IVC. There was a meta-analysis looking at multiple of them, and these are two of the famous ones, Lang and Rutsky. And here is what the invasive right atrial pressure measurement was for every estimate by looking at the pulmonary artery, at the inferior vena cava, sorry. So Rutsky is what the ASE recommend using, and this is with the invasive right atrial pressure measurement for what was predicted by looking at the inferior vena cava. So for example, here's someone who had a predicted measurement of 3, and these are the invasive measures. The red dots is what's considered accurate, and everything outside was labeled inaccurate. And this is how the number or the percent of 34 accuracy came around. So we look at the IVC, we like the IVC. I look at the IVC all the time to predict if the patient requires more volume. But in the back of my mind, I'm thinking about all of these people here where I think the right atrial pressure is low, but the person is probably overloaded. So combine this with looking at the LVEDV if you're assessing clinical status of the patient. Severe TR, again, it will create an error, and this will give you an error margin of about 24 millimeters mercury, not a small measurement error. And this is called a Blandin-Altman plot. This is a study that looked at 177 patients undergoing right heart cath and looked at the difference in systolic pulmonary artery pressure. And these are the folks who had severe TR, subset of them who had severe TR. In a Blandin-Altman plot, you have the difference plotted against the average. So for an average of millimeters of mercury of pressure difference of, an average in systolic PA pressure between the echo estimate. So this is Doppler echo minus right heart cath. This is the difference between the two. So Doppler first and right heart cath second versus the average. The mean of the difference, which is up here, the dotted line, is almost 50 millimeters of mercury. Almost everybody was shifted up. You see all of these are shifted up from 0. So it looks like the Doppler echo overestimates the pulmonary artery pressure relative to right heart cath, overestimates it in all of the measurements ranges. If you start with someone with a PA pressure of 50, you might be overestimating them here. And if you go with someone who has a PA pressure that high, you're not going to be overestimating them, but that's going to be odd to find someone with a PA pressure of more than 100. But these are folks who have severe TR. Other than severe TR, you don't get that much of a measurement error. Actually, the variability was only 15 millimeters in moderate TR and 3 millimeters in mild TR. So severe TR is a problem. That's why putting the color map on the with Doppler is important to decide if the person has severe TR.
So Z, can I ask a question?
Yeah.
Is that error then mostly coming from the measurement of the right atrial pressure? Because you can't underestimate, you really don't underestimate the velocity, right? The Doppler,
so, yeah.
You wouldn't overestimate that velocity. You would, if anything, you'd underestimate it.
So what happens with TR is that the turbulent jet, you might not catch the fastest speed. And also, it looks like the turbulence seems to result in an erroneous signal because there is more flow happening in the right atrium that's not related to the jet across the valve. So it's not really measurement of the right atrial pressure prediction from the inferior vena cava. It's actually the turbulence that's happening in the right atrium. Because using continuous wave Doppler, you don't know where you're measuring, you just know what's the fastest speed. I haven't come across anybody recommending using pulse wave Doppler in this situation, but it might be interesting to try. So yeah, the answer is really, it's not the right atrial pressure, it's really the Doppler echo measuring that transvalvular gradient. Does that answer the question? And if a person doesn't have TR, then you can't exclude pulmonary hypertension. We tend to say, well, there is no TR at all, then there must be, the pressure must be low or not high in the right ventricle. So this is a subset of folks who 137 people who had scleroderma who were being screened for pulmonary hypertension. And of those where there was no TR and they could still estimate the transvalvular gradient pressure to be less than 30 in those folks, comparing them to more than folks who had more than 30, everybody in this group underwent right heart cath for screening in scleroderma. Scleroderma is known to cause pulmonary hypertension. The sensitivity of this measurement was reasonable, but there was a negative predictive value of about 57%. So even if you don't have TR, or if your TR jet is less than 30, if your clinical suspicion is really high, you still can't rule out pulmonary hypertension. There's supposed to be a BMI correction, but I couldn't find any specific data. So in folks who are very heavy, you might underestimate, but I couldn't find any actual evidence data to suggest in which way or what magnitude. So now that you have lost your faith in the pulmonary in echo measuring pulmonary artery pressure, there is a real world applicability to this. And the real world applicability here, this was institutional data from Bordeaux in France, looking at 310 patients who were analyzed to predict, who had both an echo estimate and a right heart cath measurement of the pulmonary artery pressure. They found an R value of 0.8, a correlation of 0.8 with a really significant significance that is very good in between the two measurements. And also a Blandin-Altman plot shows that you are within 2 standard deviations here, plus minus relative to the mean, and the error in measurement between the pulmonary artery pressure estimate by echo versus right heart cath was only a few millimeters of mercury, although there is a wide spread here. And then you might, and they also they calculated the overall sensitivity and specificity after they validated their measurement cutoffs on another subset in the same institution, and they found an AUC, an area under the ROC curve here of a 0.8. It's not a perfect test, but it doesn't look too bad with a specificity of, so this is the overall sensitivity and specificity. This was the subset of validation of 0.8 and 0.6, so 86% and 66%, 87 and 66. They found that the BMI didn't really result in a big difference in the measurement. It was not a predictor of failure of measurement. Heart rate was not. Systolic blood pressure, delay between getting the echo and the cath, although in all of their subjects, the echo and the cath were done within 2 days difference. But if there was a day versus less than a day, that didn't predict a big variability. And the skill of the operator was not a big factor either. And having poor ultrasound window, although these were all skilled, and they decided only to include those with reasonable ultrasound window and good ultrasound window, was not a predictor of the variability. And then the question comes: really, only one study from France in Bordeaux? Really, yeah, that's the biggest study that we have. This was a meta-analysis that looked, and there are the ends of the meta-analyses. You can see none of them really exceeded what they had in that study of 310 subjects. Those 2 studies are kind of the major ones here, and they had a sensitivity of 85, specificity of 55, sensitivity of 58, specificity of 87, comparing echo and right heart cath in lung diseases. In cardiac disease, I was absolutely surprised because cardiologists are known to do very large studies to validate their data. There is not much, there isn't anything. And this is a study from 2011. and the study from France was 2014. This is a very nice way to represent all of the clinical trials that I showed you earlier in the previous slide, and by size of the clinical trial, and something that's called hierarchical summary receiver operating characteristics curve, where you can see this line and the dot represent the sensitivity and specificity of using echo in measuring pulmonary artery pressure. So let's go back to one more question. So now you have your tools and you have a measurement, and you're going to try to apply it and try to get the pulmonary artery pressure estimate. So you have a tricuspid regurgitant jet velocity of 3.4 meters per second, a CVP of 15 centimeters, and this gives you an SPAP of how much? So shoot, what was Bernoulli's equation? It's 4 times the square of this plus this in millimeters mercury. So go ahead. Can you use the calculator? You can use a calculator if you want. You can use an online calculator, or you can do the calculation yourself. So I'm gonna do it right here. 3.4 times 3.4. Okay. So if you're trying to answer, yeah, there you go. Now it's starting to load up.
We thought that was intentional.
All right, so this is a trick question. The trick here is, I gave you the CVP in centimeters of water. You're supposed to convert it to millimeters of mercury. This was intentional. Okay. And the right answer is 57 millimeters mercury, because as you convert to millimeters of mercury, you have to take 2/3 of the centimeters of water. So this is a measurement problem that I face a lot in the ICU when I'm measuring the CVP, and I don't know if the report that's being given to me is millimeters of mercury or centimeters of water. Does it make a big difference? Probably not. 4 millimeters is okay within the measurement error anyway of ±5. Okay, so now, instead of using, what is this? Yeah, so instead of actually using the measurement itself of the pulmonary artery pressure, the Society of Echocardiography, British and European Society of Echocardiography, they say, don't do this, just use a predictor of, do you have pulmonary hypertension or you don't have pulmonary hypertension, and go after that and do a right heart cath, because that's what you're gonna use to decide on the therapy anyway. And the way they do it is by measuring the TR velocity jet, absolutely. And if the number is more than 3.4, then you don't have to do anything else. You have a high chance of having pulmonary hypertension. But if the number is less than 2.8 or between 2.8 and 3.4, then you have to look at echo surrogate measurements. And those are, we're gonna go over those next. So if you do 2.8, you're gonna have 31 millimeters. If you have 3.4, you're gonna have 46 millimeters, just to give you show you where you are at the extremes. Okay. And those surrogates, this is the +2, are LV and RV measurements, PA measurements, and IVC and right atrium. This looks a little bit scary, but we'll go over it one by one. So the LV and RV, one is the basal RV to LV diameter high. Is it more than 1? That means, is the RV bigger than the LV? So you just measure it at the base if you want, or you can eyeball it if you want, at the tricuspid valve and at the mitral valve, and decide, is this distance bigger than this distance? Then this qualifies as 1 point. You only need 2 points. The second one is the interventricular septum flattening, or which is called the LV eccentricity index of more than 1, which means, is this circle in short axis round or is it D-shaped? So you're familiar with these. This is the basal ratio, apical 4 without foreshortening. Measure the at end diastole. If the RV to LV is more than 1, then you get a point. The eccentricity index says you measure perpendicular to the septum from a parasternal short axis, and then parallel to the septum, and then at the mid-papillary level. And if the division of D1 to D2, D2 to D1 is more than 1.1, then this is abnormal. This would be a D-shaped septum. The second set are the pulmonary artery measurements, and these are a little bit tricky. And they include the RVOT Doppler acceleration time, or a notch. So you measure the Doppler acceleration time, or if you find a notch, then that gives you a point. Early diastolic PR velocity, so pulmonary regurg velocity. The pulmonary artery, seeing the pulmonary artery is not that easy, but if you can get it and you get an early regurgitant velocity of more than 2.2 meters per second, then that qualifies as a point. And if you find the pulmonary artery trunk and you can measure its diameter and it's more than 2.5 centimeters or 25 millimeters, then that's the point. Again, the RVOT acceleration time, you go at the parasternal short axis very high, and then you measure the acceleration time from the right ventricle of the flow going through the pulmonary artery. The jet is going to be going away from you. You put pulse wave Doppler in this situation because you want the measurement immediately underneath the valve. And this distance here, acceleration time from the start of the jet until the peak of the jet, this time should be should be more than 105 milliseconds. This should be less. It should be actually, I inverted this, should be less than 105 milliseconds would be abnormal. Normal is a slow jet. When the jet becomes fast, you reach the peak very quickly. That means the pressure in the pulmonary artery is very high. So this is inverted, this sign. Or if you see a notch in the jet, a systolic notch right there, that's not supposed to happen. The jet is supposed to be smooth and curved like that. If you get a systolic notch, then this is abnormal. Although realize that this is rare to be seen in group 2 disease, group 2 pulmonary artery disease, cardiac disease. Next is the diastolic PR jet. So if you're at the pulmonary artery again, systolic parasternal short axis view, or if you go to the RVOT view, which is the right ventricular outflow, where as opposed to when you're at the parasternal long axis, instead of going towards the sternum, you tilt the probe away from the sternum towards the left shoulder. That's when you're in the RVOT view. You put continuous wave Doppler in the pulmonary valve, and you measure the PR jet, the regurgitant jet. If it's high, if it's more than 2.2, that's abnormal, and that gives you a point. And if you can see the pulmonary artery from parasternal short axis view, that on a high view, then that gives you a point also if the pulmonary artery is more than 2.5 centimeters or 25 millimeters. Finally, the IVC and the RA. If the IVC and the RA are, if the IVC is more than 21 millimeters with a collapsibility of less than 50 with a sniff or less than 20 with quiet respiration, then you get a point. that means the right atrial pressure is very high. This buys you a 0.4 higher chance of pulmonary artery hypertension, or pulmonary hypertension. The second measurement is the RA area, which is measured in end diastole, end ventricular diastole. If it's more than 18 centimeters square, then that gives you a point. After a while, you're gonna get used to looking at RAs, and you might decide, I'm just gonna eyeball it. I would say if you can get a good image, measure it, don't eyeball it. Again, these are the details of the measurement here, and of the IVC. If it's big and it doesn't collapse, then you have a point. If it's if the right atrial area traced at the end systole, when the ventricle is empty, just before the valve opens, and you get 18 centimeters square, the machine will calculate that for you, then you get a point. Okay, so one more question. In group 2, pulmonary hypertension, echo, there usually is which of these? Which of these you expect to see in a group 2 pulmonary hypertension? Let me see if I okay, great. So Matt, I might go over by 3 or 5 minutes.
That sounds fine.
If that works. Okay, great. So remember, the mid-systolic notch is uncommon in pulmonary hypertension that is secondary to cardiac disease. So let's go back over these one by one. Oops, this way. Yep. So in group 2 pulmonary hypertension, the right answer that I chose is rightward bowing of the interatrial septum, which a few of you chose. So right ventricular dysfunction is it just doesn't happen as much, because well, unless there is coronary artery ischemia that affects the right ventricle, that's true. But RV is kind of affected late in the game. You do get the RV, the RV affected, sorry, after the LV has completely failed, because the pressure on the RV has to travel from the LV across the pulmonary circulation. It's just not a common thing. Mid-systolic notch happens in pulmonary artery, in pulmonary hypertension, mainly secondary to PE or obstruction, but also because of type 1 pulmonary hypertension. Those are group 1 and group 3. Group 1 and group 4 are the most common reasons to find a mid-systolic notch, where the pressure is either very high, or it happens early on and not downstream the circulation, because the ventricle is trying to push. You manage to distend the pulmonary artery, but then you can't distend anything else afterwards, so the notch happens. That's how it happens. Pericardial effusion is more common in group 2. There usually is. If there is pericardial effusion, it's more likely to be in group 2 pulmonary hypertension. I don't know what I was thinking when I made the question, so skip that one. I think half of you answered this. And rightward bowing of the interatrial septum. I'm not talking about the ventricular septum here. I'm talking about interatrial septum. This is when the left atrial pressure is higher than the right atrial pressure. And you can imagine in cardiac disease that's causing a pressure phenomenon in the pulmonary circulation has to first cause a pressure phenomenon in the left atrial environment, and that is going to cause rightward bowing. So the atrial septum is going to bow from the left towards the right, and the left atrium is not going to be normal in size in heart disease, that in LV dysfunction that's causing pulmonary hypertension. So now that I threw at you all of these numbers and equations and a couple of other complicated measurements, if you want to snap a picture, this would be the slide for it. I put together here the approach to predicting pulmonary hypertension, first by measuring TR velocity and then adding 2 items if the TR jet velocity is not as high as 3.4 meters per second. You have to look at all of these. If you get 2 of these, then you're good. Here are some normal values that we started with, just as a reminder, what's normal, what's abnormal. And here is the prediction rule for the right atrial pressure so that you can add it to the transvalvular gradients that you're going to measure by using Bernoulli's principle. This is the equation that reminds you it's not just the vascular resistance that's an issue, but also cardiac output. So if you see a patient with pulmonary hypertension by history, and they show up with a normal pulmonary artery pressure, then my next worry is the patient is in heart failure. That's why they can't pump across. And this is the equation that I really liked, but I haven't seen used at all in trying to predict the pulmonary artery pressure by looking at the areas of the right pulmonary artery and the main pulmonary artery. Okay, so back to our patient. Let's say that in our patient who presented with post-COVID, 2 hours post-COVID vaccine, but with symptoms that lasted 6 months and progressively worse, you get this image. You decide, I'm not gonna take this. I'm gonna inject some bubbles, some shaken bubbles, agitated saline, and you get this picture. You decide that this is your point of maximum regurgitation between the RV and the RA. Call it 3 meters per second, 3 meters per second. That gives you squared 9 times 4, 36. You look at your views to decide, because you didn't really cross the 3.4 margin on your measurement, you want to look for 2 more supporting findings. You start with the LV and RV, the ventricular views, and you get these views. So just eyeballing basically the apical 4 view, as long as you haven't foreshortened the LV, you decide that you don't have a large ventricle that's definitely bigger than the right ventricle that's bigger than the left ventricle. And you eyeball your the diameter against the septum diameter parallel to the septum, and you decide that the eccentricity index is 1, not abnormal. You look at the pulmonary artery diameter here, and you measure it to be, I have it here, 27 millimeters. So that gets you a point. You've got 1 point already. Looking at the contour of the pulmonary artery flow, you see that it doesn't have a notch. The acceleration time is 113 milliseconds here, which is not short, so that doesn't give you a point. And then you go to the inferior vena. Oh, and oh, I skipped the end diastolic regurgitant jet was only 2 meters per second, so it's negative. You look at the inferior vena cava, you see that it does not collapse at all, and it's really big. It's about 2.5 centimeters. However, the patient in the meanwhile, I lost the presentation, but the patient in the meanwhile had gotten intubated. So, and is on positive pressure ventilation. So can you use the inferior vena cava as a measure of, as a point to add to say that the person has higher risk of pulmonary hypertension? The answer is that the American Society of Echocardiography doesn't say anything, and they say, we realize there is a limitation, and I'm going to go to my presentation in a second. We realize there is a limitation, but we don't know how to guide you around it. All right. That's where we were, and the right atrial area did not give you a point. So now here's a question. What about our patient who has 1.5 points in addition to a jet velocity that didn't qualify her for a higher risk of pulmonary hypertension? Are you going to say that she has pulmonary hypertension because the IVC is way too large for what it could be? Are you going to say that her systolic PA pressure is 45 plus minus 5 clinically correlates? Are you going to say wait until she's extubated? Or are you going to admit to the CICU, or are you going to admit to the MICU? CICU because you're going to get a better echo tomorrow, or you admit to the MICU because you know we're going to put a right heart cath in her. Okay, well, there is no right answer and there is no wrong answer, so very good. Like I said, you can't really depend on the pulmonary arterial pressure in this situation. Oops, I'm trying to just shrink this. Hold on a second. Let's see. Okay. You can't depend on the IVC anymore. You can use the pressure as 45, but you really want to know if the patient has pulmonary hypertension. I probably repeat the study when the patient is off the vent, but I think the patient is too high a risk, and I probably will end up with a right heart cath, not immediately, but after the acute illness has resolved or after the patient is optimized. So there is more to the story, and I'm not going to go over in detail over these. But if you have pericardial effusion or if you have low TAPC, you probably are dealing with more likely with a severe pulmonary hypertension situation. These two measurements of RV diameter and fractional area change are not uncommonly done, and you might have heard of the fractional area change that you can do of the LV. You can do the same thing for the RV. RIMP and the S' measurements require tissue Doppler, and the pulmonary artery valve early closure requires M mode, and it's really difficult to obtain. But if you get it and you get early closure, that's similar to the notch phenomena and the shortened shortened time to peak measurements. And there are more equations, but I'm not going to go over these. I would rather do a championship challenge and see. This is only going to repeat the same questions that we already went over, but it's another way that Paul Everywhere does their interactive things, similar to Kahoot, if you've played Kahoot before. So if you're ready, here we go. All right. Okay, the PH and enlarged PA can cause which of these? And you get only 5 seconds. All right. Nice. Lead board. Dan is on top. Everybody's 1,000, but let's see. Systolic PA pressure at rest is an important factor in. Five seconds are up. Nobody answered correctly. Okay. 3.4 meters per second and a CVP of 15 will give you timer. Okay. All right. Good. In group 2, pulmonary hypertension and echo, there usually is, remember that's my answer, not the right answer that I wanted you to choose. Okay. Nice. And finally, what about our patient? Okay, all of it is right. Okay, great. So open for questions. I know I'm over time and I apologize. A couple of technical difficulties, but if you have any questions, I'll stick around here. And stop sharing.
I think you're muted, Dr. Tabit.
Oh.
Let's try this. So,
okay, this works.
You said that pulmonary hypertension is defined by an elevated mean pulmonary artery pressure, correct? But
yes.
We're measuring systolic artery pressure, or systolic artery pressure. So, if you had someone who's dyspneic, you measured their systolic artery pressure, and it was elevated, how would you use that to how would you incorporate that into kind of your wandering through your differential and then kind of deciding what management to go on this patient?
So the cutoff for the mean, you can't use for an echo because you can only measure the systolic, although there are tricks in measuring mean and diastolic actually, but they're not reliable and not validated and not endorsed by the societies. But you use what you expect the trans. I really would use the 40 cutoff because it does actually cover a transgradient pressure plus a right atrial pressure of 5 or 8 actually, 8 and 32. So if a person's systolic pressure seems to be more than 40, then I'm going to say your risk is there. But the actual way to do it is to go through the algorithm and say, is the jet velocity more than 3.4? You're done. I don't have to measure anything else. If it's in between, do you have any of the other surrogates? Do you have 2 of the other surrogates at least to qualify you for high risk? And if you don't, then you're in a low risk area. Yeah, and that will only have you. That will only may help you decide: am I going to have the person go through an invasive procedure to actually measure the pressure and decide on effectiveness of potential treatment? Angle of correction. Somebody asked from the MICU. Angle of correction will actually fix mathematically the tricuspid jet velocity. But this only happens if you can't align your marker, your line of interrogation to the jet. The problem is not that you can't align most of the time. The problem is that you don't know that you're off by 20 degrees. So yeah, if you see yourself off axis, then either swing the beam or use the angle correction. Yeah, it's a mathematical correction, but it works. And I think the technicians, I've seen them do it. They use it in the echo techs.